Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. Today you're going to learn about prostate cancer and how men can keep their prostates happy and healthy. Today's guest is Dr. Manish Vira, the System Chief of Urology at Northwell Health Cancer Institute and the Arthur Smith Institute for Urology. Dr. Vira, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much for having me.
So let's start out by, you telling the listening audience about you and what made you want to work in this area of urology.
So I'm a urologist here. I've been here for about 17 years now. Since I was in medical school and got into the field of urology, I've always been interested in cancer, and so that is my specialty. I take care of any patient who has a urologic cancer, so that includes prostate cancer, bladder cancer, kidney cancer, as well as some other rare forms of cancer like testis or adrenal cancer.
So let's start off with the basics. What is the prostate? To be clear, how does it work? And tell me something about its function and how things can go awry with it.
Sure. So you're not alone that most people really don't know what the prostate does. They've heard of it, but primarily the function of the prostate itself is to produce fluid. We call that the seminal fluid. And that fluid bathes the sperm in the ejaculatory volume, which helps keep the sperm healthy during fertility and impregnation. But contrary to, I think, some other ideas about the prostate, it doesn't produce any particular hormones, or it doesn't have a direct impact on patients' ability to have erections or other sexual functions such as testosterone and so forth. So the primary purpose is really to produce that fluid.
So what are some of the other problems outside of prostate cancer that can occur with the prostate?
From an anatomy perspective, the prostate sits around the entrance of the bladder. So the bladder funnels down to one end of the prostate, and the urethra, that's how men escape the urine from the bladder, the urethra travels right through the middle of the prostate. And so one of the challenges, or one of the problems that men have from their prostate, has to do with inflammation or infection in the prostate, or more commonly, as men get older, the prostate tends to enlarge. And when it enlarges, that passageway, that urethra at the entrance of the bladder, gets squeezed. And when it gets squeezed, men have difficulty with the urine stream. They have difficulty with frequency of urination, urgency of urination, waking up more at night, not being able to empty their bladder. And that's really the bread and butter of what we see when it comes to the prostate in the office. Men are coming in complaining that they don't have enough time to get to the bathroom, or they're waking up 3 or 4 times a night and it's interrupting their sleep, or they have a difficult time emptying their bladder because of the weak urinary stream.
So with someone that has cancer of the prostate, does that automatically mean that their prostate will be enlarged and they will still have a problem emptying their bladder?
No. Oftentimes, the vast majority of patients that we see with prostate cancer actually don't have any symptoms at all. Prostate cancer in this day and age, when we find it because of screening and testing that we do, is generally a very small part of the actual prostate. Now, it's certainly possible that men can have both an enlarged prostate, which is causing the urinary symptoms, as well as having a prostate cancer, which may not be causing them any symptoms at all. So, of course, we always tell patients, if you have urinary symptoms that have come up and everything else, it's one of the things that we evaluate for. But by and large, in today's current medicine, most of the patients who have prostate cancer don't have urinary symptoms. Now, 20 to 30 years ago, before we had screening tests, before we had modern imaging techniques, and before patients were really aware of being screened for prostate cancer, a lot of the men who did have prostate cancer, that was their presenting symptoms, that the cancer had gotten so big that it then did cause urinary symptoms. So it's still one of the signs and symptoms of prostate cancer, but most of the patients who come in, we're finding their cancers much earlier before it causes those symptoms.
So how common is prostate cancer, and among what segment of the population would it be common?
Prostate cancer is the most common cancer diagnosed in men in the United States. I think this year, the National Cancer Institute will estimate somewhere around 300,000 men will be diagnosed with prostate cancer. In terms of which segment of the population, so first of all, age, right? So as men get older, their risk of harboring prostate cancer goes up. We rarely, very, very rarely see men less than 40 and even less than 50. That's very rare for men to have prostate cancer. But after the age of 50, the risk starts to go up. And certainly the average time or average age that patients are diagnosed with prostate cancer is somewhere in their 60s or early 70s. In terms of epidemiology and which segments of the population. So any man that has a family history of prostate cancer is at increased risk. So a brother, father, generally first-degree relatives carry the most risk in terms of genetics and hereditary cancers. We know that many of the genetic syndromes that are associated with, say, breast cancer or colon cancer, those genetic syndromes also can increase your risk of prostate cancer as well. So when I see a patient in the office and I'm asking them about their family history, I'm not only asking them about any family history of prostate cancer, but I also ask about a family history of breast cancer, ovarian cancer, and colon cancer. The other group of men that we know also have an increased, not just incidence, but tend to be more aggressive is Black or African American men. And the reasons for that are not entirely clear, but most epidemiology studies will show that amongst Black and African American men, there is an increased incidence of prostate cancer. So many of our screening efforts and education efforts are directed toward those two groups of populations because they are at higher risk. So
can prostate cancer be prevented?
That's a very good question. And over the years, there have been many, many studies looking at different vitamin supplements, diets, medications, and most of those studies have not shown a improvement. There was a large study where patients were given high doses of vitamin E and selenium because in the laboratory those vitamins seemed to have a positive effect in terms of prevention, but in those studies that was not true. What I generally tell men is that it seems that men who have a healthier diet, so diets that are low in saturated fats, higher in vegetables, fruit and vegetable portions, they seem, in a large population, they seem to have a lower risk. There is a correlation between obesity and prostate cancer as well. So healthy lifestyles in terms of not just nutrition, but also exercise and monitoring your weight is an important preventative factor. And in terms of medications, there have been a few medications that have been tested and studied, but none of them have really shown a significant impact in terms of prostate cancer prevention.
So tell me, how are we diagnosing prostate cancer?
The most common way that we diagnose prostate cancer is by a simple blood test. There's a blood test called a PSA, which stands for prostate specific antigen. And it was a protein that was identified about 40 years ago. And the good thing about that particular blood test is that really there's nothing else in the body that produces PSA besides the prostate. And so when the PSA level is rising or becomes elevated, it could be, certainly not always, but it could be a sign of prostate cancer. And so the American Urological Association, which is our national urology association, in their guidelines recommend that patients who are at risk, so men over the age of 50 or men over the age of 40 who have a risk factor, such as having a family history of prostate cancer, those men should start screening in that age group. And screening involves doing a blood test, seeing your physician. Sometimes if the blood test is elevated or as part of the evaluation, having a prostate exam. Once those things occur, then we can identify the men that may have something going on in their prostate. And so then there are some other testing and imaging and ultimately a biopsy, which is how we make the diagnosis.
So when we're doing a prostate exam, what should the male expect?
So it's not a comfortable exam. It is a rectal exam. So generally, it's a digital finger exam on the prostate. And what we are feeling for when we do the exam is that there's no hard or nodular areas in the prostate, that the prostate is symmetrical between the right and left, and that it has the consistency of a normal prostate. Now, the good thing is that with the current guidelines, not every man needs a rectal exam as part of their screening test. It's really used for men who have a higher PSA. And it's not something that has to be done every year. Most studies now have shown that we can eliminate the rectal exam for all men and use it just for specific men who have a higher PSA. And it doesn't have to be done maybe once every 3 to 4 years. And that should be sufficient from a screening standpoint.
So when you're looking at the PSA, what number are you looking at to lead you to think that this is cancer as opposed to just an enlarged prostate?
Sure. So that's a really great question. When patients look at a PSA report, if they have a PSA test done and they actually look at the report, most of the reports will say that a PSA of above 4 is considered abnormal. And when the test was first developed, that was probably true. But now, rather than looking for an absolute number, we look at what is the PSA test and what is the trend over time. So, for example, if a patient comes in and they have a PSA of 1, and then next year their PSA is 1.8 or 2, and then next year it's PSA of 3, that's somebody that I'm concerned about, that something may be going on in their prostate with related to prostate cancer. On the other hand, if I have an older gentleman who comes in and their PSA is 6, but last year it was 5.8, and the year before that it was 6.2, and it seems like that's where their baseline PSA is, that may not be worrisome at all. That could be just due to a non-cancerous condition, just like an enlarged prostate. So we don't have a specific, okay, this value is good and this value is bad. It's really, we take the PSA test in context with the patient. So what is their family history? What is their race or ethnicity? What is their previous PSAs have been? Have they had any procedures done or recent infections? So that's why we feel that as part of the screening process, it's important that process be done in concert with your physician. That sometimes we'll see these health fairs where come and get your PSA test, and patients just go get a blood test and then that's it. That's not really what we would consider proper screening. It really takes a conversation. It takes diving into the patient's history along with the blood test, and then possibly an exam as the best way to screen someone.
So what age do you begin getting a PSA, particularly for those who are at high risk?
In men that are in their high risk, we and the current guidelines will recommend that somewhere in your 40s that you have a PSA test. And again, when we talk about high risk, we're talking about men who have at least one first-degree relative with prostate cancer, or men that are Black or African-American men, or if they have a particular family history of genetic syndrome that puts them at risk for prostate cancer. And we know from previous data that if you start screening men in that age group and their PSA is less than 1.0, which is a very low PSA, then those men can probably come back and get rescreened in 2 to 3 years, or wait till the age of 50. Whereas if men have a PSA above 1.0, then we usually recommend that those men start annual screening after that. So for the high-risk men, it's really in their 40s, depending on which guidelines you look at. Some will say age 40 or age 45. In men who do not have a high risk, if they don't have that family history, then they can start screening somewhere between the age of 50 or 55, again, depending on which guidelines that you use.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today you're learning about prostate cancer and how men can keep their prostate happy and healthy. My guest today is Dr. Manish Vira, the System Chief of Urology at the Northwell Health Cancer Institute and the Arthur Smith Institute for Urology. You talked about a biopsy, and the biopsy would be for those who you are really, I guess, diagnosing the cancer. How does that happen, and what happens with a biopsy? What can the male expect?
So when a patient who has a elevated or rising PSA, and we are concerned that there may be cancer, we usually start by having the patient undergo a MRI of their prostate. And the MRI is a very high resolution X-ray of the prostate, and not only tells us about the structures around the prostate, but tells us about the tissue that's inside the prostate. And are there areas or there changes in the prostate that could suggest prostate cancer? So if a patient has an elevated PSA and then they do an MRI and the MRI shows a suspicious area or changes that could be suspicious for prostate cancer, then we do recommend a biopsy. Typically, we do the biopsies in the office. Patients come in, they are on our procedure table. We use an ultrasound, which is a thin probe that goes into the rectum, and the ultrasound using sound waves gives us kind of live pictures of the prostate. And then what we're able to do is we have a specialized software that's able to take the previous MRI that was done, take that ultrasound picture, fuse those together, and allow us to use the ultrasound to then guide a needle into the skin and into the area that looks suspicious. Although it certainly sounds daunting to undergo a biopsy, we give patients some medication to help them be relaxed. We inject a numbing medicine, lidocaine, into the skin that's above the rectum, and that allows the patients to go through the procedure fairly painlessly and able to recover pretty well. Most patients can go back to their normal activities by the next day and just wait for the results.
So what are some signs or some symptoms that a man may notice that should make them think about seeing you?
I think that, some of the men that we see, they don't have any signs or symptoms. They just have the risk factors. And so we certainly recommend that if you have one of those risk factors, you can certainly talk to your primary care physician or then ultimately see one of us in urology to just undergo a PSA test and a discussion about prostate cancer screening. But certainly I would say that any man that starts to notice that they're having changes in their urination, such as a weaker urinary stream, they're having trouble sleeping through the night, they're waking up multiple times at night to go to the bathroom, or they're finding that every time they leave the house, they're always looking for the next bathroom because they're worried that they're not going to be able to hold their urine in. Any of those signs or symptoms are reasons to come see us, because even though it may or may not be related to prostate cancer, we have lots of medications and treatments that can help improve that urinary function and ultimately improve your quality of life. So, then again, that's the majority of the patients that we see.
So tell me, if these patients are ultimately diagnosed with cancer, what are some of the varying treatment options that are available now?
Sure. One of the things when a patient has been diagnosed, they have a biopsy and they're diagnosed with prostate cancer, they come to the office, they're usually with a loved one or a family member there with them. And the first thing I always tell them is that the first question we have to answer is, based on the biopsy, based on the PSA, based on the other factors, does this cancer even really need to be treated? One of the challenges that we have in prostate cancer right now, and has been going on for the last 20 years, is that many men who have or diagnosed with prostate cancer will actually never die of prostate cancer. They'll die of another condition, a heart disease or some other medical condition. And that many patients who are diagnosed with prostate cancer, that cancer will be in the background, never really cause symptoms, and never really grow. And so when a patient first comes in with a diagnosis of prostate cancer, the first thing we do is we assess, okay, how aggressive is this cancer? There's, just like with all cancers, we talk about the grade of the cancer, high grade and low grade. And in prostate cancer, that grading system is on a scale of 1 to 5, 1 being the lowest grade and 5 being the highest grade. So if a patient has a higher grade cancer, so grade 2 or grade 3, or their PSA is very high and they need treatment, then we have many different treatments. The good news is that all of the treatments that we have are incredibly successful. They have a very high cure rate of getting rid of the cancer such that it never comes back. Sometimes the challenge is trying to figure out which one the patient wants or which one to choose, because there's no magic question or magic answer that will necessarily give them that answer. But in general, we tell patients there's a surgical option. We can do what we call a robotic prostatectomy. So that's a minimally invasive laparoscopic robotic procedure. We go in and remove the prostate and remove the cancer. There is a radiation-based options where radiation is delivered to the prostate to kill the cancer as well as kill the rest of the prostate tissue and cure any other seeds of prostate cancer. There is a treatment modality we call focal therapy. And so for some men who have an isolated cancer in one portion of the prostate, we can direct our treatment just to that portion of the prostate and use thermal energy like something called cryotherapy, which is cooling and freezing the tissue to extreme temperatures. There's a newer technology that uses ultrasound. It's called HIFU, or high intensity frequency ultrasound. And that's another way of using a high frequency ultrasound to heat the tissue to very extreme temperatures, which then kills the tissue as well. So there are actually a lot of different treatment options that are available, and all of them are very successful. And part of the challenge is figuring out which treatment is the right for that particular patient.
So you spoke about different treatment options, a lot of which are, I would imagine, cutting edge. Are there any research or any research studies out there that gives us more options, if you will, for patients who are experiencing prostate cancer?
You know, I think the cutting edge and the research options that are available are twofold. So in patients who have cancers that are just in the prostate, have not spread to other parts of the body, and are localized, much of the research that we're doing is to really help minimize the impact of our treatments on the patients. So any treatment that we do to the prostate can impact a man's urinary function, their sexual function, potentially their bowel function. And so, for example, in prostate surgeries, we are working with a company that is using a special infrared light and laser to help identify the microscopic nerves and blood vessels that help men preserve their erections after surgery. Okay. And so we're working with this a new technology to identify those nerves and vessels so that during the surgery we can preserve them. And if we can preserve them, then men can resume some of their normal activities quicker after surgery. In patients who are undergoing radiation treatments, we have some research where we're actually taking the biopsy tissue, looking at the genetics of the cancer, and then using those genetics to then either intensify the treatment because it looks like the cancer is more aggressive than what we initially thought, or perhaps even de-intensifying the treatment in patients who may not have those aggressive genes. And so those are ways that we're not only curing the cancer, but more importantly, or as importantly, trying to help preserve men's functions, you know, the urinary function and sexual function. The other big area of research is in men who have advanced prostate cancer, so cancer that has spread outside of the prostate. There is a protein that was identified that is specific to the cancer, and now that protein can be combined with a drug treatment so that they give you a medication through an intravenous injection through IV into your bloodstream. And that treatment then can be targeted to the cancer cells and deliver that treatment to the cancer cells themselves. So wherever they are that may be in your body outside of the prostate, you can treat that without having to treat or kill or affect some of the normal cells. You know, this is an exciting time in prostate cancer. Not only are we making our treatments to the prostate safer and better for men, but in men whose cancer has already spread, we're able to give treatments that can control the disease for longer and longer periods of time. And ultimately, men are able to live longer, which is ultimately, why we're here and what we do.
So what advice would you give someone who has been recently diagnosed with prostate cancer or a family member who wants to support that person? What would you say to them?
So the first thing I tell most of my patients is to, first of all, take a deep breath. Prostate cancer, of course, is a scary diagnosis, and no one ever wants to hear that call or those words being said. But prostate cancer is different than a lot of the other cancers that we see. Its natural history tends to be a lot longer. It takes a long time for the cancer to evolve. So what I always tell patients is that when you're first diagnosed is really take the time to do your own research, talk to your physician, make sure that you understand where you are in the spectrum of prostate cancer, what your treatment options are, what are the pros and cons of each treatment option, And don't feel rushed. Don't feel like you should never feel pressured into doing something because something bad is going to happen. I think that's oftentimes one of the fallacies that patients have is they come in, they're diagnosed, they're like, I want treatment tomorrow. And part of my job is to help calm their fears, help them relax, and make sure that they're able to take in all the information, process information, because although I have a lot of great treatments to give and to offer patients, I want to make sure that that treatment is the right treatment for that particular patient, depending on what's important to them, how they want their treatment to go. And that takes some time. It takes some thought, it takes some reflection. And sometimes patients have to talk to multiple people. The other advice I always give to patients is don't come alone. Bring a friend, bring a family member, bring someone that you trust who can be there with you, not only to support you during that discussion and so forth, but also sometimes they have questions that you may not have thought of, and they will hear things during that consultation that maybe you didn't hear because your mind was thinking about something else. So, obviously, family support, friend support, community support is incredibly important in going through this process and dealing with, the treatments and recovering and ultimately getting back to your normal life.
So very briefly, how do we find you?
We can find us on a website. If you northwell.edu, it has all the information about Northwell and all of our facilities, as well as our Cancer Institute. And you can make online appointments. We have a phone number, 516-734-8500, that gets to our main office. And our staff will be more than happy to help navigate you to seeing the right physician, whether it's me or one of my other partners who specialize in other areas of urology.
Well, thank you for being here, Dr. Manish A. Vira, the System Chief of Urology at Northwell Health Cancer Institute and the Arthur Smith Institute for Urology. We hope you stay healthy and continue to do the great work that you're doing. And thanks for being here with us today.
Thank you so much for having me. It was my pleasure, and happy to do this again anytime.
This is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.